Sir, good evening.
Good evening. Good evening. Start.
Sorry. Net type.
Start. Tamasикണ്ട.
Start, sir.
Background join you.
So, very good evening to all. On behalf of IAP Kerala and IAP Calicut, I welcome all of you for today's PG teaching session. I request our President, Dr. Jose to say a few words.
Good evening to all.
Good evening to all.
Is it audible?
Is it audible?
And
Yes, sir. Yes, sir.
Echo വരുന്നുണ്ടോ? Okay. Good evening to all. Today, the IAP Kozhikode is hosting our IAP Kerala PG clinical programs. So I would say thank IAP Kozhikode for arranging one of the common issues in PG training programs. So pre-time issues. So we have another expert in today the leading faculty, Dr. Anand sir is there, along with the Dr. Rahul and that we are going to have a very good academic clinical discussion. With this said, I over to Dr. Vishnu for further proceedings.
So, to introduce our faculty for today, we have Dr. Anand Tamar, who is a senior consultant in neonatology at Astamim's Hospital, Calicut. He's also a PG teacher for the past 15 years. Along with him, we have Dr. Rahul Ilaparambat, consultant neonatologist at ICRA Hospital, Calicut. And we have Dr. Shijia Sherin, who's presenting the case today. She's a first-year primary DNB postgraduate candidate at Astamim's, Calicut. Over to you, Anand, sir.
Yeah, good evening all. Good evening, teachers. Today we shall be discussing a newborn case. Neonatology, unlike older children, it rarely poses any diagnostic dilemmas or diagnostic conundrums, and most often candidates can expect this as a short case. But it is even if it is so, I think today's discussion will be useful for from the point of view of a practicing pediatrician also. I think without wasting time, let us start the proceedings. Dr. Shijia?
Yes, sir. I'm audible?
Yeah, you're audible. Yeah.
Is the slide visible, sir?
Yeah, it is visible. You can start.
Okay. So, good evening, everyone. Today, I'm going to present a case of a preterm baby.
Dr. Shijia, your audio is not clear.
Sir, 1 minute, sir. Actually, this slides are not moving, sir. 1 second.
No, yeah.
Shijia, just slides once more. Yeah.
Sir, it's not moving.
Use your arrow keys.
Sir, I'm trying, sir. I'm trying, sir. 1 second.
Okay.
Yeah, now it is moving.
Yes, sir. So once again, sorry for the delay. Present in the case of a growing preterm, he was presented to our unit at 40 weeks of gestation with complaints of persistent oxygen requirement and inadequate weight gain. The baby was Master ABC with date of birth of 16/2/23 at 1:05 a.m. He was born at 28 week of gestation with presented to our unit at 90 days of life with corrected gestational age of 40 weeks. And the history was informed by the mother and the reliability is good. So since since the case is regarding a preterm infant, I would like to start from the antenatal history. He was born at 24 years for a G2A1 mother. First gravida was a molar pregnancy for which DNA was done, and this was the second pregnancy. It was a spontaneous conception with last menstrual LMP was on 4/8/22 and the cycles were regular, and pregnancy was confirmed by a urine pregnancy test done at 4 weeks. Regular antenatal visits were done and she was immunized as per protocol. Going to the first trimester in detail, there was no history of any fever with rash, painful lymphadenopathy or PET exposure in the mother. There was no history of any bleeding PV and no history of any drug intake other than iron, calcium and folic acid throughout this pregnancy. There was no history of any suggestive of any radiation exposure. Dating scan was done and EDD was said to be on 11/5/23. And going to the second trimester, she felt the quickening at 5th month of gestation. There was no history of any gestational diabetes mellitus or hypothyroidism. And she has done the anomaly scan at 5th month, which was said to be normal. And she also received 2 doses of TD. And in the third trimester, she was diagnosed with pregnancy-induced hypertension and she was started on oral labetalol. She continued to appreciate good fetal movements and there was no history of any fever, UTI, or preterm premature rupture of membrane or bleeding PV. Her weight gain during the entire pregnancy was 11 kg and she was admitted at 28 week of gestation with high blood pressure. And during the time USG was done, which showed abnormal Doppler. She has received antenatal steroids and was completed 1 day prior to delivery. There was no history of any lower abdominal pain or fever. And then to the birth history, the baby was born at 28 week of gestation by an emergency LSCS in view of preeclampsia. The birth weight was 850 grams. He was small for gestational age according to the Intergroup 21 chart, and the baby did not cry at birth and cried only after resuscitation. Liquor was clear. And in detail, the baby was ventilated for 2 weeks and he has received 1 dose of surfactant at 4th hour of life. And also mother was told that he had medicines for heart and also had some bloodstream infection for which he has received appropriate antibiotic. The baby was shifted to oxygen support by 2 weeks of age. And regarding the urine and meconium, mother doesn't remember. Going to the feeding in detail, mother saw the baby and started giving expressed breast milk by day of life 5 of life, and full tube feeds was given by day of life 20 with both expressed breast milk and top feeds. KMC was started giving from day of life 20, which was a 30-minute session, which was done twice daily. Oral feeds was attempted on day of life 56 and direct feeds attempted on day of life 64, but both were unsuccessful due to choking spells with cyanosis. So then baby remained active and alert while on O2, and mother was told that this persistent need of oxygen is a cause of concern. And during this hospital stay, baby's brain growth was done by USG by scanning and was told to be normal. And eye screen was also done twice and was also reported to be normal. Now the baby was remaining on full tube feeds with 30 ml second hourly. And baby is unimmunized till now. And he was born to a 28-year-old father and 24-year-old mother as the first child of non-consanguineous marriage. And father was an engineer and mother is a housewife, and he belonged to upper middle class by modified Kuppusamy scale. Then going to the examination of newborn.
Yeah, Shijia, can you stop? I think since you have finished the history, we will first discuss the history. Can you just summarize the history for us and go back to the first slide again?
Okay, sir.
Yeah, just summarize the history.
So, summary, the case was regarding Master ABC, a very preterm SGA male baby born to G2A1 mother at 28 weeks of gestation, who presented to our unit at 40 weeks of corrected gestational age with complaints of persistent oxygen requirement and inadequate weight gain. The baby's history is suggestive of difficulty initiating oral feeds and direct breastfeeds.
Okay, so what do you have in your mind when you hear the history? A baby who was born at preterm and who at term also is dependent on oxygen.
So baby is having more than 28 days, baby is requiring oxygen. So baby has to be said to have some chronic lung condition, mostly a BPD.
Okay, can you go to the next slide? Yeah, you mentioned the baby was a very preterm baby. So what do you exactly mean by very preterm?
So the preterms are classified into extreme preterm, very preterm, moderate preterm, and late preterm. Less than 28 weeks are said to be extreme preterm. 28 to 32 weeks are said to be very preterm, and moderate preterm is 32 to 33 plus 6 weeks, and late preterm is 34 to 36 plus 6 weeks.
Yeah, when you're mentioning the gestation cutoffs, always remember to don't mention the cutoffs alone. 28 to 31 bar 6 weeks, okay, or 31 completed weeks. That would be a better way of defining. And you mentioned that the corrected gestation age is 40 weeks, right? So what do you mean by gestational age, Dr. Shijia? How do you define gestational age?
Gestational age is calculated from the last menstrual period, date of last LMP. It is calculated from
first
LMP.
day of last menstrual period to the date of birth. That is what is gestational age. Okay. And what about post-menstrual age?
Post-menstrual age is the gestational age plus the chronological age, like how many days the baby has been born.
Okay. And what about corrected gestational age?
It is the chronological age, which to be reduced by how many days or weeks before 40 weeks of gestation. Like how many before 40 weeks the baby has born.
Exactly. So gestational age is the terminology that we use to assess the baby at the time of birth. And as the baby is growing in NICU, mostly we tend to use post-menstrual age actually. And once the baby is to be shifted out, discharged, and then onward, we start using this corrected gestational age actually. So simply speaking, how many weeks the baby has grown beyond 40 weeks? 40 weeks, if you take a term, how many weeks the baby has grown beyond that? That would be the corrected gestational age actually. So if the baby is at present 44 weeks, that is 4 weeks ahead of 40 weeks, corrected gestational age would be 4 weeks for that baby. Okay. So until how long do you use this correction for gestational age? Up to what year of life?
Up to 3 years of life, sir. 2 to 3 years of life.
Yeah, some references say 2 years. There are some references which say 3 years also. So why do you feel this correction is needed?
Because the baby will have some consequences. Baby's weight should be monitored. The neurodevelopment should be assessed since it's a preterm. So the baby, the evaluation should be continued till 3 years of life.
Not only that, Shijia, these babies, you should not compare this baby with a term baby. These babies may take more time to achieve the normal developmental milestones, and also they may take more time to achieve the same level of growth to come up on par with a term baby. That roughly said to be around 2 to 3 years. Most of them tend to catch up. But however, you should remember that this is not a hard and fast cutoff. Suppose if you find a growing preterm who has not caught up, of course, you have to rule out other diseases, but don't get worried. Give him more time to do so. Dr. Rahul, can you come in?
Yes, sir. I'm here. So, Shijia, you said for development, we use corrected gestation, right? So, which is other area where you use corrected gestational age? Apart from development.
Anthropometry also we use the corrected gestational age.
Yes. So anthropometry also you will be using corrected gestational age apart from development, right?
Sir.
So which are the other areas where you will not use this corrected gestational age? You will go according to chronological age. Which are the other areas? What do you think?
Immunization we use mostly post-menstrual.
Very good. Yes. So immunization you'll be using the chronological age. It is not the corrected gestation. You'll be using chronological age for immunization, right? And also for feeding. For feeding, say to start complementary feeding, you will be using chronological age rather than corrected gestation weight, right?
Yes, sir.
Okay. We can move on to the next slide then.
Yeah, you mentioned the baby, the mother was G2 and A1. Okay, right. So what is the significance of abortion in antenatal history, Dr. Shijia?
Recurrent abortions is a cause of concern if there is preterm labor. We have to evaluate for further
You see,
infection.
whenever you hear the history of abortion, always make it a point to understand whether it was an induced abortion or it was a spontaneous abortion. Okay. If it is spontaneous abortion, we are looking at many maternal ailments and illnesses can cause, but from a neonatology point of view, we are more worried regarding any genetic issues, because
Yes,
as much as 50% of spontaneous abortions may have some genetic background to that. Can you define gravidity for me?
Gravidity is the number of times the mother has become pregnant.
And what about parity?
Parity is the number of times the mother had a pregnancy which has crossed the period of viability, say 28 weeks.
Okay. And what point you should remember when you are describing a parity of multiple pregnancy? Suppose a mother has delivered twins.
The parity is considered to be 1 even if it's a twin.
Okay. And Dr. Rahul?
Yes. Shijia,
Yes, sir.
you said the LMPs were regular, right?
And
the baby is born at 28 weeks of gestation. Say suppose the LMPs are irregular in this case, and what is the best way to assess the gestation? Antenatally,
a first trimester scanning by crown drum length can give an approximate EDD, sir.
Okay, so which is better, crown drum length or LMP?
Obviously, scanning, sir. Even though we said to be the periods are regular, they can have some irregularity.
Yeah. So LMP rather than LMP, it is the first trimester ultrasound by measuring the crown drum length is a better marker for assessing the gestation or for telling the EDD. Yeah. So suppose you don't have a scan.
Yes,
and the cycles are irregular and the baby is born.
Yes,
so how do you assess the gestation? You're not sure of the gestation. So what is the method of assessing the gestation in these babies?
We have gestation assessment scores like new Ballard, expanded Ballard scores, and all we can use it.
Okay. So
what is the accuracy of new Ballard score, Shijia? How accurate is new Ballard score?
It's said to be accurate by plus or minus 2 weeks, sir.
2 weeks. And what about the first trimester dating scan?
Plus or minus by 1 week, sir. Maximum 7 days.
As the gestation increases, the reliability of ultrasonogram comes down. In the first trimester, we go for crown rump length plus or minus 1 week. The second trimester, other indices are taken into account, not the crown rump length. Indices like biparietal diameter, femur length, abdominal circumference, etc. And in the second trimester, accuracy again varies. It goes up to plus or minus 2 weeks. And the least reliable would be the third trimester, where the accuracy can vary even as much as 1 month, actually. So remember that Ballard score also is not 100% perfect. Okay.
Okay, sir.
And you mentioned about Ballard score. So just to discuss that, what is the difference between the old Ballard score and the new Ballard score system?
The expanded Ballard score system has taken into consideration up from 20 weeks to 44 weeks. And it can be even calculated up to 96 hours of life.
Okay.
And,
okay. Yeah, and the new Ballard or the original Ballard score was actually for 26 to 44 weeks. It was described, and the correct time frame described for the original Ballard score was assessing 30 to 42 hours of life. And also, the score used to start from 0 for the old Ballard score, whereas for the new Ballard score, it starts from the minimum score is -1 actually. Okay, so these are some of the other points. So the new expanded Ballard score means you are widening the range of gestation, which can be assessed.
Okay.
So what are the two components in Ballard score, major components under which it has been assessed?
The physical maturity and the neurological maturity.
Yes. So neuromuscular, right? The physical maturity and the neuromuscular maturity, which is being assessed. Okay. So
any flip side for this Ballard score, Dr. Shijia, any flip side? Any reason why it cannot become reliable in a baby who has been delivered? You see in a sick baby who needs resuscitation in the labor room, who ends up on ventilator, maybe getting sedation, maybe having some neurological issues. Such is the correct assessment of neurological maturity is confounded by the sickness of the baby. So in such conditions, only the physical criteria may be more reliable. Okay, so that is why that is the importance of the dating scan you have in the first trimester. It gives you so much of information and value. It is 100% more reliable actually.
Okay.
Yeah.
You can go to the next slide, easier.
Dr. Rahul, I think maybe can you discuss the vaccination part, immunization?
Yes, I think so. So it's coming, and the immunization comes in the next slide.
Okay, fine. Dr. Shijia, what about the bleeding PV? What is the significance of bleeding PV when it occurs at 2 different times of pregnancy? Suppose a mother is at 16 weeks, another mother bleeds at 30 weeks.
So the bleeding PV is said to be occur before the period of viability, say 28 weeks. It's said to be a threatened abortion. If it happens more than 28 weeks, it fall into the criteria of antepartum hemorrhage. So for further workup should be done.
Okay. First trimester bleeding more in favor of abortion, and later bleeding that we have to more think of antepartum hemorrhage. Okay. And you mentioned regarding the history of drug intake other than iron, calcium, and folic acid. One point you have to remember, based on the depending on the scenario that you get, is that if you ever doubt the compliance of medications from the pot of mother, it would be a good idea to probe indirectly, ask her indirect questions. How many tablets she used to take, how frequently, and how many tablets received from the health center, and was she able to finish it off? These indirect questions also can be asked. And always remember, the folic acid administration should ideally start before the conception and after the pregnancy has started. Can you just name some teratogenic drugs for us?
Examples like lithium can cause teratogens. And, anti-epileptics like phenytoin, valproate. Okay.
And how do you classify them?
That according to the category A, B, C, D, and X. Classified according.
So originally the FDA described these categories A, B, C, D, and X, but in 2015 they have stopped using this categorization, and they prefer to use the term pregnancy and lactation labeling route, PLLR actually. So if you go to their website, there is a PLLR where detailed information of adverse or harmful implications are mentioned both for lactating women as well as for the pregnant women. So we should be aware of this fact. Okay. Dr. Rahul, any points?
Yes, I think that's it, sir. Sorry, we have one. We have disturbances from one of the participants. Dr. Dheeraj, can you please mute yourself? Dr. Dheeraj. Okay, fine. So we can move on to the next slide, Dr. Shijia.
Sir.
So here you said anomaly scan, right?
Yes, sir.
So there is no history of GDM. So gestational diabetes, what are the complications that you expect in a baby when the baby is delivered?
The gestational diabetes baby could be a large for gestational age baby with maybe risk for hypoglycemia is higher, and other metabolic abnormalities like hypocalcemia. And baby also will have some risk factors for cardiac disorders.
So what are the cardiac disorders that you expect in a baby who is born to a mother with gestational diabetes or infant of a diabetic mother?
It is said to be most common is like asymmetric septal hypertrophy in an infant. Most common congenital abnormality. And VSTs and ASTs are also.
What else can be there? They can have lesions like TDA or tetralogy. All these things are described in babies of infant of a diabetic mother, right?
This diabetes can affect almost any system in the baby's body. Okay, especially the first trimester diabetes. If it is not adequately controlled, the baby can have something called as diabetic embryopathy. Okay, later on, if the diabetes is not well controlled, the baby is described to have a diabetic fetopathy. So microcephaly is one condition which is described in antenatal GDM, actually, gestational diabetes. So if you have a microcephaly case in antenatal history, this point is very pertinent. And of course, that Rahul mentioned congenital anomalies like ASD, VSD, TGA, and all have been described. Then neural tube defects have been described in diabetes mellitus, gut atresia, anorectal malformation, lazy colon syndrome, hydroureteronephrosis, renal, and skeletal dysplasias also. You would have heard of sacral agenesis and all. So another point to note is that what about pre-gestational and gestational diabetes? Do they make any difference? Is any one entity more riskier than the other?
Both are more equally riskier.
Yeah. In any condition which is not poorly controlled is equally riskier. And what about hypothyroidism? Mother is hypothyroid, inadequately treated, because we all know that the fetus also can produce thyroid hormones. So is it important mother having hypothyroidism which is not adequately treated?
Yes, fetal thyroid production is very low compared to the requirement of fetus. So fetus need mother's thyroxine hormone for neurodevelopment.
Yeah, so roughly from the 10th week of gestation onwards, the fetus starts producing some amount of thyroid hormone. But the point to remember is that the fetus is mostly dependent on the maternal hormone, especially in the first trimester. Okay. And in the second and third trimester also, even though the fetal thyroid levels go on increasing, still the baby is dependent on maternal thyroid. And that is why be aware of the fact that the gynecologists, they have a low threshold for starting thyroid treatment for pregnant women. I think the TSH cutoff of around 3 or so is used for diagnosing hypo in antenatal visits, actually.
Yes, it is. Yes. Right. So you mentioned, Anand sir has mentioned that almost all the systems are involved if the diabetes is not controlled adequately, right? And also these gestational diabetes mothers, will they have polyhydramnios or oligohydramnios?
They have polyhydramnios. Risk for polyhydramnios is higher.
So why do they develop polyhydramnios? Is there any particular reason?
Risk for gut atresia, sir.
Probably that is one. If not, if the baby is well without any problem.
I don't know, sir. Why?
Okay. They can have something called the polyuria, right? So hyperglycemia is there, so they can develop polyuria. So that can result in polyhydramnios, right?
Okay.
And coming to the antenatal scan, 5th month, which was normal. Okay. So have you heard of the term TIFA? Do you know TIFFA, TIFA? Have you heard of the name?
Yes,
TIFA
sir.
scan.
Yes,
Have you heard of
anomalies
that?
and targeted imaging for fetal anomalies. Something.
Targeted?
Imaging for fetal.
Yes. So this is a targeted. It's another name for anomalies. It is targeted imaging for fetal anomalies. That is TIFA scan. Right. So received 2 doses of TD vaccine. So what was given previously instead of TD? First, tetanus vaccine, right?
Yes, sir.
So what is the course of that? How do they give TD vaccine in pregnancy?
It is first dose is given as early as possible when mother knows she is pregnant, and the second dose is repeated after 4 weeks of first dose.
Okay. Say suppose the mother comes for a second pregnancy.
Okay. It's if the mother was immunized just within 3 years of last immunization, only 1 dose of TD was required just before delivery.
Okay, very good. So let me ask you one more question.
Any other vaccine which can be given for mothers? We know that live viral vaccines are generally avoided. Any other thing? Probably in coming years, it might come up.
One cellular pertussis is discussing whether one dose
probably
mother
that
should.
might come up. Another thing you PGs have to be aware is that antenatal therapy for RSV also is coming up. It has been approved and licensed in, I think, in some European countries. RSV to the mother to protect the baby, actually. So down the lane, that thing also can come up. Dr. Rahul, carry on, please.
Yeah. Okay. And why do you think TD is advised nowadays rather than TT? That is tetanus, rather than tetanus alone. A small dose of diphtheria is added for a vaccine. What do you think is the reason?
Because diphtheria outbreaks are more increasing nowadays. Maybe to immunize the baby prior.
Yeah, so the diphtheria outbreak, no, the diphtheria cases are more and more coming in adolescent age groups rather than it is shifting towards the adolescent age group where the vaccine effect is waning slowly. So that is where you get the outbreaks. Even in Kerala, we had outbreaks in, I think, 6 or 7 years ago. So, and in Western studies, they have proven that administering the diphtheria vaccine along with the tetanus in the adolescent age group helps in reducing the incidence of diphtheria disease again in the community. And even now, the pertussis is also they are trying to include in the vaccination in the adolescent age group instead of TD. Now Tdap is under discussion. Okay.
Okay, sir.
Yeah. So
Next slide. Dr. Shijia, the PIH on oral labetalol, so beta blockers to mothers, any neonatal implications?
Some said that there is hypoglycemia, risk for hypoglycemia when oral labetalol is used. Studies.
Neonatal hypoglycemia, and even there are case reports of apnea and bradycardia also in the newborn, in the labor room. Okay, more need of resuscitation. So keep this in mind. This was a preterm whose mother was on labetalol. And you mentioned regarding the history of fever, UTI, and PPRI. What is the significance of fever, especially in this case, actually? Suppose if this mother had high-grade fever, what is the importance of that?
One is the baby had some sepsis in the history. So this maternal fever could be a cause of, could be an indication. Chorea amniotis can produce fetal sepsis. Then high-grade fever was said to have some risk factors for cerebral palsy.
That is another point. Whenever the mother has got high-grade fever, probably as part of infection, various inflammatory cytokines can get released, which can possibly damage a growing preterm brain. Actually, cytokine-induced damage to the periventricular area, and so there is also an independent risk factor for cerebral palsy. And regarding this PPROM, can you expand PPROM for me?
Preterm premature rupture of membrane.
Yeah. Preterm premature rupture. And the point to remember here is that whenever you're eliciting history, it is important to know exactly when the membrane is ruptured. The most dangerous scenario is the membranes rupture, and after a few hours like that, then the mother delivers. Okay. There is something called spontaneous preterm labor also. What happens in spontaneous preterm labor? The mother comes, the membrane ruptures, immediately she delivers a baby. This may not be as risky as the other scenario. So the preterm, pre-labor rupture of membranes is actually more riskier for the baby. So in the history, it is very important to note the duration also. Okay.
Okay.
And suppose the mother has got fever, abdominal pain and all, what condition did you diagnose? Abdominal pain, tender abdomen.
Could be a case of UTI, urinary tract infection, most common.
Okay, then it can also be the so-called chorioamnionitis. Chorioamnionitis is not used nowadays. Nowadays, the terminology preferred is what terminology?
Prepartum, intrapartum infection.
Yeah, intrapartum infection and inflammation or both. Okay. And not only fever, even the grade of fever also is important, which may be difficult to obtain from history, but keep this in mind. Dr. Rahul?
Yeah. So, CJ, you've said about abnormal Doppler, right?
Yes, sir.
So, which is the abnormal Doppler that you are worried of? So, which makes the obstetrician to terminate pregnancy?
The umbilical artery showing reversal of flow required urgent termination.
Okay, either it is reversal or absent.
Absent
and diastolic flow or reversal of the flow. So that will make the obstetrician terminate the pregnancy, right?
Sir.
And something about antenatal steroids. You've said antenatal steroids are given 1 day prior to delivery. Which is the antenatal steroid that is preferred in our country, or which is the government of India recommended steroid?
Dexamethasone, sir, because of its low cost and availability.
And why do you say so? What is the other reason? Is there any other reason?
Like betamethasone, that acetate phosphate mixture 1:1 ratio was not available in our country. So mostly
okay, very good. So it is that dexamethasone, which is the government of India recommended antenatal steroids for given to the mothers. It is not betamethasone because we don't have the appropriate preparation in our country. So, say, how do you give it? What is the dose?
So dexamethasone is given as 6 mg second hourly for doses, sir. 2 days completed.
Second hourly.
12 hourly, sir. 12 hourly.
So, so it is dexamethasone which is given, and say, is there any contraindication? If I tell you, is there any contraindication for giving antenatal steroids?
First one will be an hypersensitivity reaction to the steroids, and some studies shown that unlikely,
okay.
but some studies say chorioamnionitis infection.
Chorioamnionitis, yes. So chorioamnionitis is one condition where you will not give antenatal steroids, right? And say gestational diabetes and steroids. What do you think? So,
it's not contraindicated, sir. Overweighing the.
So can it be given? Say mother is having gestational diabetes. So can it be given?
If the diabetes is appropriately maintained or controlled, we can give. Sir.
Okay. So it can be given to mothers with gestational diabetes.
Dr. Rahul, just a second. Even if the diabetes is not so well controlled, then also you can give steroids and scale up the insulin if needed. The basic idea is you should utilize every possible opportunity to give antenatal steroids to a preterm mother. That is the main message here. Okay. And even I think chorioamnionitis also, some of the literature says caution. They use the word caution in chorioamnionitis or intrauterine infection, rather than mentioning it is absolute contraindication like that. So the basic idea is to utilize every opportunity to provide steroids. And what are the morbidities that this prevents?
It prevents the respiratory distress syndrome like lung maturity. It is known to prevent NEC, necrotizing enterocolitis, and IVH, intraventricular hemorrhage. And
also mortality, newborn, preterm mortality also is another thing which is influenced by antenatal steroids. Okay. Now, suppose if this baby had not received antenatal steroids and you're having a baby in your NICU without any steroid exposure, so would you consider giving postnatal steroids?
Postnatal steroids was not recommended, sir.
It is not recommended. Why is it so? Why can't you give? Why can't it help surfactant maturation postnatal also?
I don't know, sir.
Yeah, postnatal steroids should not be used in premature babies. The only situation where it is possibly described is bronchopulmonary dysplasia. That too, not much 100% evidence-based. But postnatal steroids can harm the baby. It can harm the baby neurodevelopmentally, actually. So that also can increase the risk of cerebral palsy. So even if you are putting postnatal steroids for a diagnosed bronchopulmonary dysplasia with proper indications, ideally you are supposed to get a written consent from the parents regarding the pros and cons of steroids, and only then proceed ahead. Okay. And can you give repeated doses of antenatal steroids to your mother?
One suggested like rescue dose was suggested. If mother received more than 2 weeks, mother has received a steroid, 1 dose of steroid was recommended to give. One single dose.
Yeah, the baby is actually less than 34 weeks of gestation. Mother has already received a course 2 weeks before. But again, unfortunately, she is at impending risk of labor within the next 1 week. If you think so, you can give 1 single shot. Antenatal. Okay, Dr. Rahul, anything else?
Nothing. I think since she has answered almost all the questions, I'll ask one question.
Yeah.
Why dexamethasone and betamethasone are given and not say prednisolone or hydrocortisone for as antenatal steroids? Shirya, please unmute yourself.
Maybe it crosses placenta, sir. I don't know, sir. Maybe it crosses placenta.
It has to. What it does is these things are metabolized by the placental enzymes. So that is why these are not regularly used. So okay. Yeah.
Next slide.
Before going to the next slide, I'll ask one. So, is there anything apart from antenatal steroids that helps for the baby? Any other drug that can be given apart from antenatal steroids for neuroprotection?
Antenatal magnesium sulfate has been shown to cause.
Okay. Yes, very good. Is that given in this mother or any idea?
No, this mother has not received.
Not
okay.
Right. We'll move on to the next slide then. Next slide.
It's not moving, sir. 1 second.
Yeah, here you mentioned the baby was an SGA. How do you classify these babies as they are born?
Based on growth charts, sir. We mostly use Fenton or Intergrowth 21 charts, and this baby, according to Intergrowth 21, falls below the 10th centile, appropriate for the gestation.
So what is the advantage of using IG21, Intergrowth 21 in our setup?
It was said that it involves more Indian population,
not more Indian population. It is a multi-centric study like the WHO growth charts that we have, but it has got an Indian representation. Okay. And from, I think, from North India, Nagpur actually. And so how do you decide whether to go for Fenton or whether to go for intergrowth charts? Some people say that the representation of lower gestational ages is less adequate in intergrowth charts. So at the time of birth, there are units which follow Fenton, and as the baby grows, they switch over to intergrowth charts. Okay. And another point is that whether be it revised Fenton has been revised again, and the intergrowth charts, it naturally merges into the WHO growth charts at 40 weeks of gestation. So the monitoring of the growth becomes more easy. And besides these, there are many other named growth charts also, okay, like Olsen, Babison, and Benda and all, but you should be familiar with these two, I think. And Fenton, actually, do you really think that it is suitable for our Indian population, Fenton?
We mostly use Fenton.
Because if you plot on Fenton, most of our babies will be growing way below the 3rd percentile, okay? Because Fenton was not used in our population, okay? And another problem is that Fenton actually is based on foreign population, and therefore our babies may grow very low if you use Fenton growth chart. But more important than growth chart is to stick on to one growth chart and follow the trend. That is more important, okay?
Okay, sir.
And in Fenton growth chart, I think after 40 weeks, the WHO growth chart is incorporated. It is like extrapolated as using the WHO growth chart. And also, I think the number is also very high in Fenton. The number of babies that has been used to make this chart is, I think it is in 4 or 5 million babies are being used, has been used compared to intergrowth, which is in 20 or 30,000, I guess.
Yeah, Fenton is actually a reference chart where they did the study in a real world scenario, whereas intergrowth chart was more a standardized one in an ideal world scenario.
Okay, sir.
Is it intrauterine growth chart or postnatal growth chart? What is it called?
Postnatal growth charts. Postnatal.
These are intrauterine growth charts. So
okay.
the babies are just after delivery, these babies are being counted. Right? So the weight of the baby just after being delivered in ideal scenario, not in ideal scenario is being used in the growth chart, most ideal.
Okay.
Yeah. So it is these are intrauterine growth charts.
Okay.
Right. So resuscitation. So now the baby is delivered, right? Your baby is delivered. It was 850 grams, was SCA. Did not cry at birth. So you are in the labor room.
Yes, sir.
So what do you think is the labor room temperature that is ideal or optimal for the baby?
26 to 28 degrees Celsius. That to be optimal.
26 to 28 degrees Celsius. Yes, good. And so what are the precautions that you take? Say you've heard of the term 6 cleans, 5 cleans or 6 cleans. Have you heard of the term 6 cleans?
Yes, sir. Hands, 6 clean hands, clean surface, clean cord, clean thread.
Okay.
And clean blade. Clean blades.
Clean blade, yes. Clean cord cutting instrument. Then you have the 3 cleans: clean hands, clean surface, and then the clean perineum. The 3 cleans, and then something related to cord is clean cord tie, clean cord cutting instrument, and clean cord care. So these are the 6 cleans. And also postgraduates, please make a note of the warm chain. So what are the 10 steps in warm chain? Just make it a note. This can be asked as a question, right? So baby required some form of support during the transition, right? So
yes,
what is the percentage of oxygen that is being used for resuscitation? How do you start resuscitation? If you're aware of NRP, neonatal resuscitation protocol.
According to NRP, yes, sir. According to NRP protocol, if it's a baby more than 35 weeks, we can use 21% of room air, FiO2.
Okay. Yes.
If it is less than
And
35.
what about preterm baby? Say your baby 28. Your baby is 28 weeks, right? So for this baby, how would have you have started?
So the recommendation is 21 to 30% of FiO2.
Yes. So for preterm babies, you start with 21 to 30% depending on the saturation. So you go by the saturation guide. You have a saturation guide like 1 minute, and this is the saturation that is required. 1 to 5, 1 to 3 up till 5 to till 10 minutes. You have saturation chart. So you go by the saturation chart and titrate the oxygen, right? Okay. I think we can go to the next slide.
Next slide. Yeah, Dr. Shijia, ventilated for 2 weeks. So are you happy with this?
No, sir. It's a cause of concern if the baby is ventilated longer periods.
Ideally, we target and aim to avoid ventilation. That is why to avoid ventilation, what do you use? Early delivery room CPAP. Okay? Early onset CPAP as the earliest sign of distress, actually. So there is definitely a point of concern here. And the baby received 1 shot of surfactant, okay, at 4 hours of life. Can you give for a repeat dose of surfactants also, or do you always confine to 1 single dose?
No, sir. Repeated doses were also recommended. Second dose.
Yeah. So what is the main criterion that you decide on surfactant administration?
There is a new guideline for regarding how much FiO2 is required. How is the unit score?
So even the IAP STG also have mentioned the FiO2 cutoffs for giving the first shot of surfactant and also for the second shot of surfactant. And ventilated for 2 weeks. Why are you worrying actually? What damage are you causing to the baby?
Lung could be long-term lung injury.
Long-term lung injury. And remember that we are administering oxygen. Oxygen also is a drug. It also can cause free radical injury. Okay. Again, the bloodstream infections also cytokine-induced damage can occur. And did the mother give any history of jaundice or anything like that? Because that word is absent in your slides. Or the mother was not aware?
Mother was not aware of any phototherapy given
Mostly
to the baby.
in preterms, during rounds, they take the cutoffs and initiate phototherapy. And so in amidst all the other major problems that baby had, probably the mother would not have been made aware of that actually.
Yes, sir.
Dr. Rahul?
Yeah. So you told about surfactant. So
Yes,
how
sir.
was the surfactant? What are the methods of administration of surfactant?
One is ensure method, sir, which we are commonly using.
Ensure method.
And there is LISA method,
Okay.
less
So
invasive.
what is ensure? What about
Ensure intubate, give
less
surfactant.
invasive?
Intubate,
Yes.
then give surfactant, and then we can extubate to CPAP. That is ensure method.
Okay. And yeah. So what is LISA? You told LISA, right?
LISA is less invasive surfactant administration. By laryngoscopy, LMA we can give.
Is there any other method by which any other terminology? Have you heard of the term MIST? MIST?
Minimum invasive by a tube like NG
Minimally
tube.
invasive surfactant therapy, right? What do you think the way by which the surfactant is given for this baby?
By direct through the ventilated.
Yeah, so the baby was ventilated. So it is just you have to disconnect the tube and then give the surfactant and then connect back to the ventilator, right? And so something about, you mentioned something about the medicines for the heart. So
Yes,
what
sir.
is it? What it could be from the history?
Since it's a very preterm baby, the baby could have a risk for PDA, hemodynamically significant PDA. So the baby would have received a medicine for closure of PDA.
Okay, so what are the medicines that are described? What are that are given for PDA?
Paracetamol, IV paracetamol is recommended. And then indomethacin, which has been used.
Yes.
And then
and what else?
Indomethacin.
Anything else?
Sir, one more drug.
Which medicine do you give for fever in children?
I can see it in the chat box. It is in the chat box. Ibuprofen it is.
Ibuprofen.
Okay. So what are the other complications that can develop in preterm babies, you know? Say from the labor room, starting from the labor room.
Like cardiac complications, sir?
No, the complications. general complication that a preterm baby can develop? So we
Hypoglycemia.
mentioned something about the warm chain, right?
Sir, warm chain. Hypothermia.
So they can have hypothermia. Yes. Then
Hypoglycemia. Babies have.
hypoglycemia. Yes.
Then
So you can go system by system or from top to bottom. It will be easy. So in the brain, what can be there?
cerebral
I can give some
hemorrhage,
examples
sir.
in the start of-
IVH, hemorrhage, intraventricular
Yes,
hemorrhage.
intraventricular hemorrhage. They can develop intraventricular hemorrhage. Then coming to the eyes, they can develop retinopathy of prematurity.
Actually,
Down the line, coming to the heart, they can have
PDA.
hemodynamically significant PDA. So what are the clinical, how do you assess clinically for PDA? How do you say that the PDA is significant or there is a PDA which is significant?
There is something, the baby will have high bounding pulses with
Bounding pulse can be there, yes.
then narrow pulse, wide pulse pressure.
Wide pulse pressure, you can see the wide pulse pressure.
And we will have a difficulty in weaning of the ventilator settings for this baby.
Yes.
Would be a cause of HSPD. We can suspect.
Yeah, tachycardia is there. Recording will be hyperdynamic. So these are some of the signs that from which you'll say that and the baby may deteriorate. So the baby will be fine and say day 3, day 4, and sometimes the baby can deteriorate, and the cause could be one of the cause of deterioration is PDA in these babies. Okay.
Can we move to the next slide?
Yes, sir.
Yeah. Here another point of note is that the baby, probably the baby was too sick that they were not able to feed the baby. So ideally, when do you give the first feed for the baby?
First feed can be given as early as possible once the baby is stabilized through OG. We can use it.
What do you call that? What do you call that?
Trophic feeds or minimal enteral
Minimal
nutrition.
enteral nutrition. Okay. Is there any contraindication for that? Almost no. Okay, unless the baby is on having hypotension on multiple inotropes, very high FiO2, barring this unusual or surgical abdomen, barring these situations, for almost any baby you should provide trophic feeding. Okay, suppose if mother's milk is not available, what is the next best option?
From breast milk, donor milk can be given, sir.
Mother's own
available.
milk, MOM. If that is not there, pasteurized donor milk. That is second option. If still that is not available, then you can at least start trophic feeding by using formula feeding. Okay. Now, what about the rate of advancement of feed? We saw that the baby was on full feed by 20 days of life. Are you happy here, or would you have preferred it the other way around?
Early full feed is the recommended, like rapid increment.
So do you think that rapid advancement can predispose the baby to necrotizing enterocolitis? Do you feel like that?
It could be, it is a risk, sir, but still outweighing the condition, we can go on increasing.
The rate of advancement of feeds is not a major threat for NEC. That is what the recent evidence says. That is why they are talking about rapid advancement of feed versus slow advancement of feed. Okay. When do you call rapid? Because slow means somewhere around 10 to 20 ml per kg per day, whereas rapid means most of the studies they have used 30 to 40 ml per kg per day. Okay. And what about this KMC for 30 minutes? What is the point in KMC? What should not be done in KMC actually? Do not give KMC for ultra short amount of period, because KMC better be given for prolonged amount of time, for even hours altogether. And if you give KMC for short duration, actually that may be causing more detrimental problem for the baby, because you're putting the baby, immediately shifting out the baby, not allowing the baby and the mother to settle down. Okay, so that is a point that you should remember when you're tackling this KMC in history. And Dr. Rahul?
Yeah, one more point I want to add on in the previous one regarding feeding. Actually, even if the baby is sick, you can as soon as the mother is stable after delivery, as soon as the mother is stable, you can ask the mother to express milk, and even if it is few drops, it can be just smeared on the baby's mouth, even if the baby is sick. So that can be done. And baby is on orogastric feeding, right? So what do you think is why the orogastric feeding is preferred and not the nasogastric feeding in newborn? In preterm or whatever.
Babies are obligatory nasal breathers, so it could be it can cause further obstruction for the baby.
Yeah.
Mm.
Good idea. Yeah. So these babies are obligatory nasal breathers. So that means that they breathe mostly through the nose. So if you put something through the nose, that can cause airway resistance and it can cause difficulty in feeding for the baby. So that is why orogastric tubing is preferred rather than nasogastric tubing.
And many babies, we say sucking on the orogastric tube. So probably that might give some neurodevelopmental positive support also.
Yeah. So you have attempted oral feeds on this baby at 34 weeks.
Mm.
Do you think this is the apt time to attempt oral feeds?
34 weeks. Yes, sir. No, 32 to 34 weeks, we can attempt palliative feeds. And if the more than 34 weeks, we can go for direct breastfeeding.
Why do you think so? Why 34 weeks? Why that cutoff is there? 32 to 34. Why the cutoff is there?
Because of the development of the baby regarding the suck and swallow coordination to develop, sir. It will take time.
Okay, so usually by around 32 to 34 weeks, these things develop. Suck, swallow, and one more thing is there. What else?
No, normal respiration.
Yeah, so that is suck, swallow, and breathing. So these three are the important ones: suck, swallow, breathing. Okay, so by around 32 to 34 weeks, we do start palliative feeds. It can vary. It is not hard and fast rule. Sometimes some babies may be ready a bit early. Some babies it may not be possible to feed them around 32 to 34. Sometimes we may have to wait for another 2 weeks or two.
Yeah,
to start
it is
palliative
actually a
feed.
trial
It depends
and
on
error
baby to
method.
baby. Yeah.
From the bedside, you feed the baby, observe the baby, see for the vitals, and then decide and take it on like that.
Yeah.
And also there are some scoring systems are also available for the oral readiness scoring system, but practically we go by the bedside assessment actually. And in this baby, why do you think this baby was not able to achieve oral feeding like that? Because we know that the baby is having bronchopulmonary dysplasia, and BPD babies may have delay in attaining suck-swallow coordination. Okay, they may take more time when compared to the normal babies.
Okay, sir.
Dr. Rahul? Anything else, Dr. Rahul? Can we move on?
Just one more question. Was this milk fortified? Do you know anything about that one? Fortification. Did the mother give any history of?
But by the time mother has reached us, mother doesn't have any expressed breast milk. Baby was mostly on top feed. So fortification.
Okay.
It's not possible.
Okay, fine. So what is the importance of fortification?
So the fortification will supply the baby high calories, proteins, and micronutrients, which are deficient in others.
Okay. So preterm milk is mostly deficient in nutrients compared to deficient in nutrients, because these preterm babies need more nutrients compared to the term babies, right? So because the nutrient accretion takes place mostly in the third trimester, so the baby came out early, so we have to supply extra nutrition. So that is one reason why we have to fortify the milk. What is it? What is being used in your unit?
Lactodex is used.
HMF, right? Human milk, lactodex, HMF. So human milk fortifiers are used. Okay, so as postgraduates, you should know like what are the contents of this HMF, human milk fortifiers. 1 gram contains how many amounts of each substance, each nutrient. Okay, I think we can move on to the next slide.
What about here? I think the striking point is that the eye screening was done twice. Are you happy with that?
No, sir. Since the baby is coming under high risk area, the eye screening should has been done twice weekly. So
yeah. What do you think the most probable reason would have been? Probably, I think the mother would not have been aware of the number of ROPs done. She might have forgotten the count actually. I don't think any level 3 unit will miss on ROP, because ROP is very important. It's potentially blinding condition. And most of the ROP visits, how many visits this baby should have had by the time this baby received 40 weeks?
6 visits at least, sir.
Yeah, 1 to 2 weekly as per the ophthalmologist recommendation. Can it, in any situation, do you need to monitor more frequently, even in matter of days, ROP?
If the baby has some avascular zone, previous ROP showing?
Generally, when you are having suspicion of pre-plus disease, the ophthalmologist may decide to review even in a matter of 3 or 4 days, actually, as per their decision, actually. And generally, ROP screening is done on what, gestational age or the postnatal age?
Postnatal age.
Both can be taken. And so in any situation where you do an early ROP screening rather than waiting for 4 weeks.
If the baby has falls into high risk area, like extreme preterm, like this baby, very preterm and all, we should have given after 2 weeks.
Less than 1.8, or in any situation where you are not sure about the gestational age of the baby. The mother is not having adequate documents, you're not having the correct idea. In such situation also, rather than taking risk, better for an early ROP screening, actually. Dr. Rahul?
I think, how long till you'll screen these babies?
Till the retina has become normally vascularized, complete development of retina. Till that time, fundus will
usually it will take around 40 to 44 weeks for complete vascularization. Till 44 weeks is the correct time the complete vascularization of this thing. Or if suppose the baby is having a stage 1 or 2 ROP, you have to follow up till it regresses completely. Okay. So till that time,
ROP for a term baby, Dr. Shizia?
Term baby, I don't know, sir.
Generally, routinely it is not recommended. But one point to remember is that any baby who is extremely sick and has had an unstable course in NICU, if the neonatologist wants, he can perform an ROP even on term baby also. Okay, keep this in mind. Not only for even term baby, ROP has been reported. Dr. Rahul, I interrupted you. Please carry on.
No problem. So one more thing from your practicing point of view, I want to mention is ROP is potentially a medico-legal condition. It is even if you say the baby is very well, say if the baby is less than 34 weeks, if you feel that the baby is well and discharged without ROP screening, and if the baby comes back with say blindness, baby developed ROP somehow and comes back with blindness, they can sue you. So you have to be very careful in dealing with preterm babies, especially in terms of ROP screening. So what happens is if you're not screened properly, they end up in blindness. So that is very important. That will affect the quality of life of the baby as well, and also important in medico-legal point of view. Okay. Right. So
can we move on to examination, Dr. Rahul? I think.
Yeah, I think yes.
Just a point, important point. Previous slide, Dr. Shijia. Unimmunized. Do you think this kid could have been immunized?
Yes, baby should have been immunized by the 40 weeks before that. So first vaccine should have received within 24 hours of life.
So do you give vaccines for a sick preterm also in NICU who's on ventilator and all?
Hepatitis B is only contraindicated.
Generally, we wait until the baby stabilizes. Okay, even though until the baby stabilizes. And what about hepatitis B?
It's said to be controversies, like it should not be given before 2 kgs of weight.
Some people believe that less than 2 kg, the immunogenicity of hepatitis B may not be adequate, and therefore, So when do you give for preterm babies, low birth weight babies and all?
Once the baby reaches 2 kg, on follow-up we can give.
Stable, What does the purple book say, the IAP purple book? Either at the time of discharge or 1 month later, irrespective of the gestational birth weight of the baby. And they also say that if you give it to a premature baby or a low birth weight baby, do not count it in the 3 doses. You give 3 doses in addition also, like that. That is what the new purple book says in IAP. Okay. Dr. Rahul, any other point to add here?
No, I think that's fine.
Okay. So move on to the examination, Dr. Shijia.
Okay. So going on with the examination of baby was lying on the bed with upper limb and lower limb in flexion, awake with eyes open.
And just one point to add about the vaccination part in the immunization history. All of us neonatologists should be asking about 3 vaccines. One is the influenza vaccine also. Of course, TDAP is to be recommended by all of us. From 28 week onwards to maybe 34 weeks, it should be given. A little late is the timing. because you want the immunization antibody to be covering up to 6 months. So for the Tdap, the timing is from 28 week onwards to 34 weeks. But for the influenza, a little earlier will be the ideal because I want to protect the mother also. There's a controversy. If you give too early, that will be giving the mother safety, but it may not last for the 6 months of the postnatal period for the baby. As you rightly said, maybe we are going to get the RSV vaccination, which are important in the coming years. In Western countries, with a lot more of this RSV, and we also is likely in the post-COVID era. So it may come. It is now recommended above 60, and in other countries, pregnant ladies. So these 3 vaccines are likely to come in this thing. We can give at least 2, influenza vaccine and the Tdap part. Regarding Shijia mentioning about the hepatitis at this part, the 2 kg recommendation has gone. The chronological age and at the earliest, because even otherwise you are giving the 3 doses, and what is the problem is not the safety part. The efficacy, if you are giving at the preterm baby, maybe 60-62% only, you need not bother. Whatever benefit you give it before discharge, once the baby is stable, don't wait for the 28 days or the 2 kg. So that's the recommendation. Maybe if it is not enough, but the other 3 will be given in the national schedule. So better to give. That is a policy. Thank you. Thank you. A nice teaching session, and Shijia is also batting very well. Thank you.
Thank you, sir.
And she's a first-year student, sir.
Thank you, sir. Thank you, sir. Thank you for that valid point. Shijia, carry on.
Sir. Going on with the examination of baby, baby was lying on the bed in upper limb and lower limb inflection, awake with eyes open, on nasal cannula with 1 liter O2, and baby was euthymic and pink. And vitals recorded were heart rate of 130 per minute, regular rhythm, no radiofemoral delay, all peripheral pulses were palpable, respiratory rate of 68 per minute with saturation maintained with 1 liter of O2, and mean blood pressure was 52 millimeter of mercury. Temperature was measured at 37 degrees Celsius and capillary filling time was normal. And going on with the head to foot examination, baby's head size and shape was normal, anterior fontanelle appears normal, ear, eyes, chest, spine and limbs appear normal, and external genitalia normal with bilateral testes palpable. There was no dysmorphic features or any neurocutaneous markers, and no cleft palate is seen, and umbilical stem look healthy. And going on with the anthropometry, the weight of baby was 2.4 kg. It falls below the 3rd centile intergrowth 21 chart, and length was 46 centimeter. It also falls below the 3rd centile, and head circumference was 31 centimeter, which also falls below the 3rd centile. And this is the weight of the baby plotted, and at 40 weeks, baby was 2.4 kg. And this is the intergrowth 21 chart showing the length of the baby and the head circumference of the baby. So going on with the examination of nervous system, baby was alert, awake, post-feeds. With cranial nerve examination, first nerve was not assessed. Second cranial nerve, pupils were equal and reacting bilaterally with red reflex present. 3, 4, 6 showed dorsal movement and spontaneous eye movement. 5th was elicited as corner reflex normal. And 7th, baby has been closing both eyes during vigorous crying and rooting was present. And 8th cranial nerve examination showed normal started reflex. 9, 10 gag reflex present with no pooling of secretion. 11 is not assessed and no tongue fasciculation noted. Motor system examination, baby has symmetrical movement. There was only no positive movements were noted. And going on with the tone, baby has generalized tone of flexion of all extremities, and active tone was elicited. On pull to sit, baby has head lag. On vertical position, there was no slippage, no bilateral lower limb appears flexed. And on ventral suspension, head lifting till midline was done. There was normal spine curvature. There is flexion in bilateral upper limb and lower limb. And baby was kept on prone position, where baby lies on flat abdomen with head turns to one side with flexed lower limb. And passive tone was elicited while baby was lying on the back, fully flexed lower limb and partially flexed upper limb. Popliteal angle was 80 degrees. Heel to ear showed heel just crossing the umbilicus. Scarf sign just crossing the midline, and square window was 30 degrees, and there was good arm recoil. and reflexes were elicited. Deep and plantar extensor were normal, and plantar was extensor, and neonatal reflexes were present. Moro was present and complete. Sucking and rooting reflex present. ATNR present. Palmar and plantar glass present, and stepping and placing reflex were normal. And other system examination, on respiratory system examination, child has tachypnea with minimal work of breathing, but normal vesicular breath sound were heard bilaterally, and there was no added sounds. And cardiovascular system was normal, where heart sounds were heard normal, and no murmur was had, and apex beat was palpable at 4 left intercostal space lateral to left midclavicular line. And abdomen was mildly distended and soft with no organomegaly, and bowel sounds were heard, and hernial orifices appear normal. And coming to the diagnosis, very preterm baby, very preterm SGA male baby at corrected gestational age of 40 weeks with diagnosis of bronchopulmonary dysplasia, failure to thrive, and high-risk newborn.
Can you go back to the first slide, examination, Dr. Shejia? Yeah, so awake with eyes open. Okay, so can what do you mean by that? You're describing what of the baby? What is being described here?
The status of the
states of newborn. That should be the terminology. Okay, the consciousness is assessed by the terminology state of the newborn. Initially, the baby would be sleeping, and then the baby would be opening the eyes and simply looking around. And later, the baby will be showing some amount of movements. And the vigorous state, stage 5, the baby will be crying and vigorously moving all the things. So states of the newborn is being described here. And what about the lying on the bed with upper limb and lower limb in flexion? Just imagine this baby lying in upper limb and lower limb in extension. Would that make a difference?
Yes, sir. It could be a hypotonia. Babies may have. If the baby.
Yeah. So when the baby matures from 28 weeks to 40 weeks, at 28 weeks, what do you expect for this baby?
28 weeks, baby could have extension of both lower limb and upper limb.
And somewhere around 32 to 36, both, even the lower limb start getting flexed, upper limb starts getting flexed. And at 40 weeks, both upper limb and lower limb should be flexed. And what is the progression of tone like? How do you describe that? The tone first increases in the lower limb or upper limb?
Lower limb, sir.
Chordocephalic and distoproximal. These two words have to be used. Chordocephalic and distoproximal. Okay. And what happens after that? Now the baby goes home after 40 weeks. What happens after that? Well, what happens to the tone? Tone actually decreases. As the baby grows, the tone decreases in the reverse order. Because imagine if the baby continues to remain like this, how is the baby going to reach out for objects, develop all the fine motor development and all? You understand? So as the baby grows, in the upper limb tone, that occurs in the reverse direction, the reduction of tone from cephalocaudal direction. And only if the lower limb tone comes down, only then the baby can start crawling and walking and all. So keep this in mind. Next slide. Dr. Rahul, anything in this slide? Do you want to? You are muted, Dr. Rahul. You are muted.
Sorry. Dr. Shejia?
Sir.
You just can go back to the slide. You said euthermic, right? Why do you say the baby is euthermic?
Baby was covered in clothes, temperature normal.
By examination, how can you say like the baby is euthermic? Baby is euthermic and pink, right? So,
not sir. Only we can say the baby is pink.
You can, but by feeling the baby, then you can say feel for the trunk as well for the periphery.
Yes.
Say if the peripheries are cold, what do you say? Say the trunk is warm and the peripheries are cold. What do you call that state?
It could be
baby is in what? Baby is in what stress?
Baby was
in cold stress, right?
Cold stress.
So if the peripheries are warm and peripheries are cold and the trunk is warm, you call it as
cold stress.
Cold stress. And if the peripheries are cold and even the trunk is cold, you call it as hypothermia, crying hypothermia, right? And there are cutoffs like what is cold stress? It is what is the temperature above which you say, or temperature cutoff of cold stress, or what is the normal temperature of a newborn?
36.5 to 37.5.
Yes, very good. So 36.5 to 37.5 degrees Celsius. So cold stress is 36 to 36.5. So that is a period where we have to intervene. So we should not allow the baby to go in for hypothermia. So just by examination, we know that the baby is going for hypothermia. So if you feel the heat, you know that the babies are getting cold. So at that point, you have to intervene. You should not allow the baby to go in for frank hypothermia. Below 36 is hypothermia. It is there, moderate, severe hypothermia, etc. is there. So those you just can read out. Okay.
Okay, sir.
Right. Next slide, please.
Shreya, how do you measure blood pressure? Just name 2 methods of measuring blood pressure for these infants.
We can use non-invasive blood pressure, NIBP, and flush method in newborns, as
Yeah,
we told.
so all the pages learn about flush methods. If you're getting a baby in the ward side, you may not have a non-invasive monitoring. So familiarize yourself with the flush method. And how did you measure the temperature actually?
Here in this baby, we had kept the baby under preheated warmer. So we measured with skin probe of the warmer. We can use digital thermometers.
Okay, okay. So getting the core temperature, ideally what site is recommended?
Ideally, rectal temperature is recommended, but
Yeah,
we don't.
but it has got its own flip side. It may cause injury, damage and all. So practically the axillary temperature can be mentioned in the examination. And remember that the thermometer should be able to pick up low temperature also, because here we are not worried about hyperthermia or fever. We are more worried about the hypothermia aspect actually. So as Dr. Rahul said, that using the dorsum of the hand, feeling the palms and soles and comparing with the trunk. Actually, in fact, WHO recommends that in low resource settings to assess thermia like that. And can you move to the next slide? Yeah, one point I wanted to mention is that, do you mention the diagnosis as SGA, small for gestational age? What is the difference between SGA and IUGR?
IUGR we use for term babies with weight.
The basic difference, Shreya, is that it all depends upon the growth potential of the baby. Every baby will have a growth potential. So imagine a baby whose growth potential depends on many factors actually. So mostly genetic actually. So some of the babies may have a growth potential of, imagine one baby having a growth potential of reaching only 1 kilogram, and the baby is born at 1 kilogram. That is an SGA baby, small for gestational age. Imagine another baby whose real potential was a birth weight of 3 kg, but due to some placental insufficiency, the baby comes down to 1 kg and gets delivered at 1 kg. That is an IUGR baby. An IUGR baby is a baby who doesn't achieve the growth potential. So these two have to be kept in mind. And in IUGR baby, actually, you can also, because SGA versus IUGR, to differentiation, the weight alone may not help, but the clinical examination, the skin folds in the buccal area, the trunk area, like we described for older children, has been described in newborns also. There is something called clinical assessment of nutrition, CAN score. You need not memorize and apply the CAN score, but in the head-to-foot examination, at least these loose folds can be described.
Okay, sir.
And also the hair pattern and all. Okay.
Okay, sir.
Yeah, Dr. Rahul, any point to be added?
Nothing. I think it is basically a failure to thrive intrauterine. But
Next slide.
another term is SGA, the terminology that can be used instead of IUGR. And also there is something called early and late IUGR, early IUGR versus late IUGR. So those terminologies also you should be aware. So babies whose growth falters less than 32 weeks are called as early IUGR. So they have to.
Sir.
I think Dr. Rahul's audio
and here, yeah, sorry. Hello.
Hello.
Am I audible right now?
Yeah.
Okay, I think we need to speed up.
Yeah, can you move on?
Sir.
Yeah, anthropometry already. Can you show the growth charts here actually? Yeah, go to the length and head circumference. Head circumference. Yeah, so in comparison to weight, when you compare length and head circumference, do you have anything that is coming to your mind actually? Are you happy with this? Actually, one can argue that the head circumference is much more low in the growth chart when compared to the weight. Weight is at least somewhat touching the 3rd percentile, whereas head circumference is way below this. And this is a more worrying factor for me. Okay, that is another thing you should look. The way in which the head is growing, okay, which is a marker for the head growth, the brain growth actually.
Okay, sir.
Next slide. Yeah, in cranial nerves, one point I want to mention, a doll's eye movement. Okay, one point you should remember is that doll's eye movement, once the baby starts fixating its eyes and starts following your face and following objects, red ring and all, doll's eye movement may not be applicable. Doll's eye movement is ideally done before the fixation develops. And once the fixation develops, the only thing you can do is to describe the spontaneous eye movements as you're observing the baby in the awake state. And the 5th cranial nerve, other than corneal reflex, any other point which can be done for 5th cranial nerve?
Sucking, if the baby is sucking.
Sensation, the sensation over the face. So that can be utilized. Okay. And what about the pupillary reflex? Can you examine pupils for a premature baby also?
It is said to be developed from 26 to 28.
Yeah. So actually, theoretically, it can be done so. But will you force open the eyes during examination?
No, sir. We don't force.
Then how do you make the baby open the eyes if the baby is close the eyes? Actually, you can hold the baby and do some gentle rocking movements. Okay, when you do this sort of rocking movements, most of the babies will open their eyes. Okay, that is the way you should not force open the eyes, especially during examination. Next slide. Yeah, another point to remember is that in examination, the generalized flexion of all extremities, there is a general tone that you are describing. And then the active tone assessment, you should always keep in mind the baby's status also, because active tone means pulling to sit, ventral suspension and all, the baby should be reasonably stable. Keep this in mind. And this pulling to sit using the fingers may be a bit crude, especially if the mother is there. You can always hold the shoulder and try to lift the baby up. So keep this point in mind, okay?
Okay, sir.
Yeah, and this holding in midline, the head lifting till midline, always remember for a 40 weeks, it is not going to be a steady hold. The baby will be holding in the head in the midline only for a moment actually. So that is what you are looking at. Same in the case of ventral suspension also. Don't expect the baby to do a Superman fly. It will hold the head for a few moments only. Okay.
Okay, sir.
Yeah, next slide. Again, the ankle spelling is wrong. Popliteal ankle, and some people say you can compare both the angles together to look for any asymmetry. And this assessment like 80-degree and all is crude. Is there a better way of doing that? More accurate way?
What's the angle?
Angle measurement. Any instrument for that? Goniometer. Okay, there is an instrument called goniometer, mostly used in study purposes and papers and all. But for examination purpose, you can do like that. And for measuring the popliteal ankle, how do you place the thighs actually? You have to flex the thighs to the
umbilicus.
Abdomen. Flex the thighs to the abdomen and then increase. What happens to this popliteal ankle as the baby grows? What happens?
Popliteal angle decreases.
For a 28-weeker, it will be increased. And then as the baby grows, it decreases. Okay.
Decreases.
Yeah. And what about the scarf sign just crossing midline? Are you happy with that?
No, sir. By a term baby, it should have not reaching the midline.
Yeah. So probably there is a clue that this baby may be having some tinge of hypotonia somewhere. Okay. Next slide. Yeah. One practical point in examination for while measuring this plantar is that plantar, we know we stroke using fingers for newborn babies. So try not to elicit the plantar grasp. If you take the finger too much near to the base of toes, grasp reflex, plantar grasp will get elicited. So what Illingworth says is that better you confine yourself to the distal half of the lateral part of the foot. There is one practical point you should keep in mind during examination. And again, in terms of Moro, one point to remember is that the suddenness of movement is more important in Moro rather than the height to which the head is falling. So you need not just make the head fall too much because these babies are sensitive, gentle handling should be there. So that suddenness of movement is more important in Moro, especially mothers may get anxious if you are eliciting this Moro reflex. Okay. And what about the Moro in a preterm baby? Any peculiarity?
Only the first part will be developed, sir.
Their gravity muscles won't be well developed. So as soon as the second phase comes, it drops to the bed actually. Okay. And differentiating Moro from startle is a very favorite question of examiners. We are not going into that. You read about that, okay?
Yes,
And sucking, rotting we have described. And whenever you are assessing tone, any tone, better ensure that the head is kept in the midline, because if the head is deviated to any side, this ATNR can get triggered and it can affect the tone assessment on that particular side. And palmar grasp, always remember to introduce the finger from the ulnar side, okay? Because the ulnar grasp is the one that first developed before the radial grasp is developing, okay? So there is another point. And regarding stepping and placing reflex, the stepping reflex, you hold the baby on the cot and see for the alternate stepping movements. Stepping reflex has been described for the upper limbs also. If you make the baby's arm hit against a table, the baby will lift the arm and keep it on the table. That is another point you should keep in mind. And the way in which the foot is put down on the cot also is different for a preterm and a term baby. A term baby will actually move from the heel to the toe, whereas it has been described that for a preterm, sometimes the toe may hit first, and then only the heel part. So the preterm, a growing preterm will have a toe to heel stepping reflex, whereas a baby born at term will have a heel to toe stepping reflex. Okay.
Okay, sir.
Dr. Rahul, anything?
I think that is pretty much everything, sir. And PGs, they should know like when this appears and when this disappears. These are very important, like ATNR, all those things.
Yeah.
Okay.
Please proceed. Shijia, next slide. I think we'll skip all these systems because there is nothing much to describe. Go to the management part. Come to the diagnosis. One point in diagnosis. Yeah. One point I want to mention is that the terminology failure to thrive. Failure to thrive has got its own definition and generally more applied in pediatric age group, where they describe FTT as the growth coming down and crossing the 2 percentile curves and all. Such a standard definition is not there in neonatology. That thing you should keep in mind. Whenever any baby born is not growing fine and is losing weight, is there any other terminology described nowadays? It is called extrauterine growth retardation, EUGR. Okay. And EUGR has got its own set of criteria, not PACA criteria, still being debated. But one criteria says based on standard deviation. But just keep this fact in mind. Better terminology. Dr. Rahul, do you agree? EUGR would be a better terminology?
Yes, I think that would be better. Yes.
Yeah. Okay. Dr. Shijia, management. Yeah, we discussed the management. The slides are over. So what is the most important thing here that we will be focusing? We have a baby who is having bronchopulmonary dysplasia. We know that BPD has got different pharmacotherapies which have been described, steroids, diuretics, vitamin A, and all those stuff. None of them are 100% evidence-based. So what is the single most thing that you will be concentrating here?
Adequate weight gain, sir.
Growth of the baby. As if the baby grows well, the baby will achieve better alveolar growth. Okay, so what are the options that we can have to increase the growth in these babies?
We can increase the feed volume, sir.
Now, more than feed volume, in question and in the examination, you should talk of calories actually. These growing preterms, how much calories do they need?
The requirement is 140 to 160 kilocalories per kg per day.
Yeah, and the protein content required is around 4 grams per kg per day.
3 to 4.
Yeah. So in order to give more calories, if you want to increase the feed volume, you can do that. Or else if the mother is having express milk, if you want to fortify, the baby is tube fed, you can go for fortification also. Okay. Now, what are the supplements that you are going to give this baby?
Baby will need supplementation of calcium, iron, vitamin D.
Okay.
Then phosphorus supplementation.
Phosphorus is very important because what happens when the phosphorus is low and the SAP is high? How do you describe that condition?
Osteopenia of prematurity.
Osteopenia of prematurity. Dr. Rahul?
Yeah. So what is the other name for osteopenia of prematurity, Shijia?
Sir, metabolic bone.
You know?
Metabolic bone
disease. So that is a preferred terminology now, metabolic bone disease. Okay. So suppose this baby is getting discharged, so this baby is off oxygen, and so what are the pre-discharge checklists that you'll see for this baby? Pre-discharge checklist where
baby should have adequate weight gain for the past days.
Yeah.
And caregivers are trained for the feeding, regarding the feeding, weight gain, and the follow-up, everything.
Yes, very
And
good.
then-
Yes.
And the baby should have completed screening of eye, hearing, and further follow-up should be planned
Yes.
accordingly.
Yeah. So adequate weight gain should be there. The caregivers should be trained to give feeds and care of the baby. Then they have to have immunization and screening.
Immunization.
That is, immunization is important. Then screening, hearing screening is very important. Then ROP screening is there. So these things are needed before, and blood investigation. So what are the blood investigation? As Anand sir said, the metabolic bone disease, calcium, phosphorus, ALP. Then for anemia of prematurity, you have to do a hemoglobin test. Then thyroid function test you have to assess. And also you need to make sure that the ultrasound scan has been done for the baby. So there are some, say for these babies, you have to do 3, 7, 28, and then 1 scan at term. So these things has to be done for the babies before discharge. And one most important thing I want to mention is you have to do a proper pre-discharge examination. Full head to foot examination is very important, because these babies come to our NICU in a critical stage, and what we'll do is we'll straight away ventilate the baby, put the baby on ventilator, and we won't be doing a full examination in these babies. So it is always better to do a full examination, because we may miss some lesions in the back, and sometimes after intubation we may not be able to see the oral cavity. We will be missing some posterior cleft. These things can be missed.
Okay.
And another important thing is the hernial orifices, which is another area where things can go wrong. If you are not identify hernia appropriately in preterm babies, it can go in for strangulation, and you have to do resection anastomosis. So you have to identify promptly. Whenever you're examining a baby, preterm baby, just open the pampers and see the hernial inguinal region to make sure that it is normal. Okay. So what are the advices that you give to mother for taking the baby home, before taking the baby home? So what all she has to take care?
She has to take care of the feeding and post-feed burping, and baby have risk for aspiration. And a mother should know about the danger signs baby can have.
Very good. Yes.
And
so first thing is the temperature regulation. She should know. The baby has to be on warm clothes. All those things have to be put. Then feeding, how frequently the baby has to be fed. She should know how to give feeding to the baby. Then she has to have proper hand washing, prevention of infections, very important. Okay. Then, as you said, danger signs. You have to tell the mother what are the danger signs and when to seek medical care. Then how to give supplements, what are the supplements to give, and then about the next vaccination, then next ROP screening. So many things are there. You have to tell mother everything and make sure that she understood everything. It's not just like just say everything in a single burst and then go. So make sure that mother understands everything before sending the mother home. Okay.
Now, and don't forget the thyroid screening. Even if the initial screening had been normal for preterms and low birth weight, repeat screening has to be done. Okay. And now when you are referring this baby in follow-up, not only in your OP, you should follow this baby in a high-risk clinic, follow-up clinic, early intervention clinic. In other words, that terminology, early intervention, should come in the examination answer. Okay. Because these are all high-risk babies. And you should also familiarize with few early intervention assessment tests, just the names of them. There are 2 types of tests. One is screening test. The second one is diagnostic test. Okay. Screening test, just 2 of them, name them. One is anything, MKC Nair cells, Trivandrum development screening. That is number 1. Second is Denver development screening test. Okay. And the more definitive assessment would include BSID, Baby Scale of Infant Development, the Indian counterpart, DASI, Developmental Assessment Scale for Indian Infants, then Hammersmith Infant Neurological Examination. So these certain names of these tests you should be mentioning in the examination. Okay.
Okay, sir.
Can we wind up, Dr. Rahul? I think yes.
I think yes, sir. Purushottam sir, any question, any comments, sir?
Very good discussion. I was listening. And about the older generation, the initial part, Anand mentioned about the thin subcutaneous tissue and all. We used to consider 2 ways. symmetrical IUGR, asymmetrical IUGR, malnutrition type, and the hypoplastic type of IUGR babies. That is considering the Pondra index at that time. So here also, as Ananda rightly pointed out, we expect the head growth spared, and that should be following the upper centile compared to the body growth. Here, body is comparatively normal, but the length and the head is on the lower side. That is worrying, because by this time, the maturity of about 40 weeks is there. Now you expect the head circumference to be almost 35. So instead of mentioning the centile, third centile, the actual head circumference could have been mentioned. That Shija, what was the head circumference now? 34?
31 centimeters. 31 centimeters.
So that's a little worrying. You expect the head to be spared, and that is on the lower side. The prognosis part is a little worried. Because if it is a malnutrition type, the body part is gaining weight, the head should be spared, and that is on the higher centile, we expect. And we should be giving the government program, the Shalabham, all the screenings, the pulse oximetry, we are doing the ROP, a little lower numbers, the hearing screen, the visible birth defect screening, and the pulse oximetry you mentioned, the 96 in the upper right and the lower part. That is the one thing in the newborn period, but a little bit different will be in the preterm situation. But I mentioned about the dorsalis pedis and lower limb pulse in the situation. So lower limb pulse, because some of the situations of the cardiovascular problems also, of course, in this context, it's a respiratory problem, but maybe without the murmur also, we may be missing some of the cardiac problems, especially in the failure to gain weight situation, saturation. From one of the problems is cardiac. You have echo, you are done. Few of the conditions can still be missed even in the echo. That is one thing. About the thyroid, Dr. Anand rightly pointed out, the guidelines will be modified in a preterm, but 1 month of ventilated babies. Don't give much weightage to the neonatal screening thyroid. There should be need for repetition, thyroid function to be repeated. One point, I think the CDH part also. At the time of discharge, you should be monitoring whatever we have missed once again, the undescended testis part. And the one thing which we miss, the CDH and the eyes, because the early cataract also can be missed. So at the time of discharge, thoroughly one more screening for the malformations. In this case, I am a little worried because of that head circumference. Otherwise, they will come up. Thank you. Nice discussion. I learned a lot. Thank you.
Thank you.
Thank you, sir.
I think Anand is, Vishnu is there, or is anybody?
Yes, sir. Yeah. Thank you, sir. Thank you, Anand sir, Rahul, and Shrijia for that wonderful discussion. All points, relevant points were touched up in detail, and thank you very much for that enlightening class. And thank you very much, our dear senior members, Purushothaman sir and Darli madam, and all others for joining with us today. We'll be online again next Thursday with the next PG teaching session. Thank you very much.
And well done, Shrijia.
Thank you, sir.
Great job. Thank you.